Very good morning and warm welcome to Online Anesthesia Postgraduate Teaching Program on Zoom platform sponsored by ACUTE and hosted by A1 Logics and aired by Anesthesia TV. Today we are having two eminent scholars in our session of Obstetric Anesthesia. This is the last session of Obstetric Anesthesia. The first topic is postoperative multinodal acute pain management after cesarean delivery by Professor Kannan sir. Second topic is guidelines for neuraxial anesthesia following anticoagulant and antithrombotic drugs by Professor MADHUSUDAN and UPADYA sir. Today's session is coordinated by Dr. RAJESH JEYAPRAKASH. Over to you, sir.
Thank you, sir. Good morning, everyone. First of all, I would like to thank both the speakers for spending their valuable time with us in this online teaching anesthesia program to educate the postgraduates. And I welcome both the speakers who are stalwarts in obstetric anesthesia. As Edward sir mentioned earlier, we have two topics. The first topic will be delivered by Professor Dr. P.R.M.KANNAN about postoperative multimodal acute pain management after cesarean section. Ideal man to deliver such a lecture because he has a vast experience in obstetric anesthesia. He's a former head department of anesthesiology, Tirunelveli Medical College, and he is right now emeritus professor MGR Medical University, editorial board member of IJA, and a former GC member of ISA national branch. And he had delivered lots and lots of lectures in national, international and state level conferences. And is very known for his teaching the basics in anesthesia, right? Especially in obstetric anesthesia. Over to you, sir, Kannan sir, for the topic.
Hello.
Kannan sir.
Okay.
Kannan sir?
1 minute, sir. There is a problem in login.
Okay.
Hello. Screen starts.
Shall we move on to the second topic first, sir?
Okay, we will.
Yeah, that is available, sir. Sir, Edward sir, any other problem, sir?
So he is joined. He is not able to unmute. He will start the presentation.
Okay, sir. Okay.
Kannan sir.
Yes, now I should be audible. Hello? Now I am
Sir, you are
audible.
audible, sir.
Yes, sir. Kannan sir, audible, sir. Welcome, sir.
Yes.
Welcome. Kannan, audible, sir. Audible, sir.
Yes,
You can
yes,
start with your lecture.
yes. I will start sharing.
Okay. Sir.
Yes, it is visible.
Yes, sir. Yes, sir.
Yes. I
Visible,
will go ahead with that. Thank you for giving me an opportunity to talk to the postgraduate and you. The topic is postoperative multimodal acute pain management after cesarean delivery. And you are very well aware, cesarean is the most common surgery done all over the world. And it has been found out nearly 18.5 million surgery has been taking place annually. So you can understand the volume of work obstetricians and obstetric anesthetists are doing every day. Then we can ask why there is a sudden escalation of cesarean delivery. The reason is well known to all of us. That is, the maternal request is becoming the most common one, not only in India and everywhere. Not only maternal request from the family, it at an auspicious time and so on. There is also increased number of high-risk patients. Every day we are following that pre-eclampsia, elderly preemie with cardiac disease and things like that. And on the other hand, the obstetric medical legal environment is also not very friendly. So many obstetricians prefer to do cesarean, not wait for normal delivery. So all these things leads on to an escalation of cesarean delivery every year. Then the pain after cesarean delivery is something unique, and it is specific for the specific patient. It all depends upon the amount of degree of tissue injury that sensitize the peripheral nerve endings, and also the central pathway is also influenced by the fear, anxiety, and frustration and other things. There are certain unique features in cesarean. That is, we have to look into the postoperative period. What are those unique features? So since there is pain, if you use a greater opioid and a larger amount of opioids, it will delay the recovery period. So the delay in recovery periods, then it will produce an impedance of maternal and fetal or newborn bonding. All these things may lead on to postpartum depressions. Then also there is a entity very well known to all of us, chronic pain syndrome, that is more of physiological and social and economical disasters because of this chronic pain syndrome. Nowadays, the enhanced recovery that is most widely accepted requires a good postoperative analgesia. That's why the patient can easily get discharged and move around, and these are all encouraged nowadays. So how to identify the woman at risk at severe pain? One thing, a standardized approach to all patients is not appropriate, and as you know, the time to pain to resolve, sometimes it may take 2 or 3 days. Sometimes it is estimated up to 95 days. So the variations of pain perception is there among patients who comes for delivery. So how to identify younger age group, perioperative anxiety, patients with perioperative anxiety, and patients with a history of chronic pain. and other psychological factors like separation, frustration, and all these things. These patients are high-risk patients during post-operative period, and they have to have a special look into this problem. And further, special concern for cesarean delivery, unlike in other surgery, preemptive anesthesia cannot be given, because you know very well that drugs will cross over the placenta and the fetal depression may take place. So preemptive anesthesia is not always possible in cesarean. Other problem is anesthetic technique invariably for cesarean is exclusively neuraxial anesthesia. So you have to plan our post-operative anesthesia depending upon the technique of neuraxial anesthesia. Third thing, the potential analgesic drug transfer into the breastfeeding neonates is also a problem, but most of the drugs, the dosage with which we are giving to these patients do cross the breastfeeding, and it is very small amount that reaches the fetus, I mean newborn, which has no effect on them. And as early as possible, the transition from the parenteral dose to the oral dose has to be taken place so that the patient can move around. And the early mobilization enhances the mother's ability to independently look after and also the newborn is very much essential for the bonding and discharge of the patient to home. So what is the remedy for this is only the multimodal analgesia. Of course, multimodal analgesia is known to all of us present day. What is multimodal analgesia? We have a lot of drugs that act in the various places, like local anesthesia acts in the peripheral nerve endings, anti-inflammatory acts over the peripheral nerve endings, and the local anesthesia in the nerve roots, and again, local anesthesia and opioids acts in the posterior horn, substantia nigra, and centrally the opioids and alpha-2 blockers, they act. So we have a drug that acts on the peripheral nerve ending or in the nerve roots or also in the central, in the cerebral cortex, thalamus. So a combination of drug is used. Using this combination, we provide a superior pain relief and also minimize the opioid drugs so that the opioid related adverse events are to minimize as much as possible. Then it is 1979, first paper was published in anesthesiology about the neuraxial opioids. And these neuraxial opioids are given in few micrograms. They act in the G protein of the opioid receptors and inhibits they act on the potassium channels and allow the potassium to go in, and the calcium channels are blocked. So the calcium content of the nerve fibers or the receptors will be less, so that the stimulation will be less. This is the accepted mechanism of action of these opioid molecules over the in small amount on the receptors. So since then in 1979, so many drugs form of opioids are tried. Still, the morphine seems to be the best among the lot. The intrathecal morphine was standardized to use in obstetric neuraxial block. So a meta-analysis done in nearly 22 years ago, and they standardized these procedures, and they conclude that morphine with 100 to 250 micrograms is enough. The duration depending upon the dose, generally the duration lasts for about 18 to 24 hours or even sometimes 36 hours. And the lower dose, that is around 100 micrograms, when used, there will be the incidence of nausea and vomiting and pruritus will be less. And if you combine this morphine, even 50 micrograms with ketorolac, the same effect of 100 micrograms morphine is achieved. So these are all the conclusions they derived in 1999. For the past 22 years, this holds good as a good postoperative analgesia. Suppose if you want to use morphine in a epidural neuraxial block, how much to be used? Always the question arises in our mind. Nearly 20 times, that is 20:1 or 30:1 of morphine in the epidural space is good enough and is good. It gives a good analgesic effect. When we use with the single shot epidural, the dosage may be around 1.5 to 3 milligram. The fear that is there in all our minds when we use morphine is the respiratory depression. It is around 2008, a landmark study was published. In this, around 1,915 patients are examined, and what will be the incidence of respiratory depression. They have found out the incidence is when we use intrathecal morphine at a dose of 0.15, that is 150 to 0.8, 800 micrograms, the incidence of respiratory depression is around 0.26 to 3% only. And most of the cases, they starts with bradypnea. At this time, we catch this patient immediately with ventilation and other supports. We can save the patient with total apnea, from total apnea. And when we use epidural morphine at the dose of 2 to 5 milligrams, the incidence of respiratory depression is 0 to 2.5, 2.8%. Then, when respiratory depression occurs, of course, we should be able to reverse it. The sheet anchor drug is naloxone. Though naloxone half-life is short, we have to repeatedly use. Naloxone has got its own problem. It is also can produce hypertension and ventricular tachycardias and things like that. And now there are reversal by non-opioid drugs are also tried, especially drug like potassium channel blockers at carotid bodies. That is the drug is named as GAL021. These are all done in the experimental animals and also human volunteers. They block the potassium channels, and a group of drugs like known as AMPAGIN. This modulates the glutamatric respiratory neurons in the brainstem and the respiratory centers. And these are all the drugs that they are trying for Alzheimer and Parkinsonism. And this that also helps in reversing the respiratory depression. And serotonin receptors agonist is also acts within the brainstem and try to reverse the respiratory depression that is caused by morphine without reversing the analgesic effect. That is the importance of these drugs. Of course, these drugs are yet to come in clinical use, and we have to wait for that. So other intrathecal adjuvants widely used, you know very well, opioid drugs, fentanyl, sufentanil, and these are all the two drugs is very much accepted. They are the full agonist, and only thing they have, they reduces the onset of analgesic time when we add with bupivacaine, but the duration of their effect is short-lived, around 3 to 4 hours. Of course, sufentanil has an extended time, but not exceeding more than 6 hours. But when widely buprenorphine and pethidine has been used in most of us, and buprenorphine supposed to have an 18 hours of action, and pethidine nowadays was used. Nowadays it is not used because these are all not total agonists. Even buprenorphine, there are few papers about that. Anyhow, meta-analysis meta-analysis, critical meta-analysis is not done in buprenorphine, and it is not widely accepted in developed countries. Of course, lot of non-opioids are also being tried, like clonidine and dexmedetomidine. It is very well proved, and these two drugs prolong the action of analgesia, and but they don't prolong analgesia as good as morphine. Of course, steroids are also used, dexmedetomidine. This prevent the production of at the enzyme level, it prevents the production of prostaglandin that helps in. Of course, midazolam, magnesium is also tried, and magnesium sometimes in the larger dose can produce demyelination intrathecally. That is a questionable one. And these are all the drugs that is definitely used along the action, but how good they are for postoperative analgesia is not very well established. So the gold standard drug, nearly morphine, still stays in the clinical practice. For instance, if you take clonidine, there are two meta-analytic papers that is published in 2017 and 18, and they conclude following things. Clonidine prolonged the duration of sensory block to 128 minutes, and the motor block for about 44 minutes extra. It increases the sedation. It did not increase the risk of hypotension, pruritus, vomiting, nausea, and things like that. And the Apgar score are also not influenced by this. So, clonidine can be used to prolong the action of the local anesthetic, but it may not be as good as narcotic drugs like morphine. Coming to regional blocks in cesarean section. As a part of enhanced recovery from surgery, this not only this intrathecal morphine, the regional anesthesia also plays an important role. So, regional anesthesia improves the analgesia, it decreases the postoperative opioid requirement, and severe incisional pain is relieved so that the chronic pain syndrome can be avoided. What are all the techniques of local anesthetic? Will be one of the easiest technique will be the local anesthetic with wound infiltration and infusion. A single dose of wound infiltration with bupivacaine, the analgesic duration can extend up to 4 to 12 hours, and a continuous wound infiltration with a catheter in the subfacial plane can prolong this analgesia for more than 24 to 36 hours. So there is no optimal dosage or local, the dose of local anesthesia has been established, and the infusion regime and all that not established. And of course, in practice, we can use 0.125 to 0.25% of bupivacaine or levobupivacaine. The initial volume of infiltration may be around 20 ml, and then we can use a 5 ml per hour dosage for 24 to 48 hours. One thing we have to be very careful, this may not, the absolute sterility should be maintained because it is directly into the wound and it should not cause any infection. Of course, when to use infiltration technique, whenever we do cesarean under GA, sometimes you are forced to do cesarean under GA because of the patient condition, or the patient may be very adamant that he don't want a spinal anesthesia. And sometimes if we don't use neuraxial morphine, this local infiltration will be very useful. Nowadays, much talked about lysosomal bupivacaine supposed to act for a longer time. But a paper published recently, a comparison of lysosomal bupivacaine and conventional local anesthetic agent in regional anesthesia, a systematic review they conclude that currently there is limited evidence suggested that the liposomal bupivacaine provides a longer analgesia than conventional local anesthetic when used in regional anesthesia. So, the silver bullet of liposomal bupivacaine is questioned. Other regional anesthesia technique will be the bilateral transverse abdominal plane block, the TAP block, where all these nerves from 7th intercostal to 11th intercostal, the subcostal, and also the ilioinguinal nerve, they lie in between the internal oblique and transversalis, and you can catch them at this point by using an ultrasound. So this TAP block is a very simple technique. It grossly reduces the opioid usage in this patient. The patient satisfaction is very good, and the duration will definitely, if you use bupivacaine or even if you use ropivacaine with steroids, it acts for more than 12 to 36 hours sometimes, a single dose. And the dosage is around 20 ml in each side with 0.25% in an adult woman is convenient. But usually when the patient by weight, when we think about, it is 0.4 ml per kilogram body weight, and that is the acceptable dose. The technique, previously it was done in a plain technique, double pop technique. With the advent of all the ultrasound available nowadays, it is an easiest technique. Here you can very well see the fat, the external oblique, internal oblique, and transversalis, and this is the target area. And once you give the drug, you can see the beautifully enlarged space plus where the drug is deposited. This is a very simple technique. And then the quadratus lumborum block, where the block is given more posteriorly. And this Balkanov, who has first popularized this TAP block, is also published in 2015 a paper on quadratus lumborum block on cesareans, and he concludes bilateral quadratus lumborum block provides greater analgesia and reduces the postoperative opioids consumption in patients who did not receive intrathecal morphine. So if the patient receives intrathecal morphine, that is enough. But if for some reason if they don't receive intrathecal morphine, this quadratus lumborum block is a very good analgesic technique. Then positioning the patient in like this lateral position, and then the sonoanatomy is very simple. This is the transverse process of the L4 vertebra, and this is quadratus lumborum. This is the erector spinae muscle, and this is muscle in front, and this is the target area. So what is the advantage of quadratus lumborum block? That is, it spreads along the thoracolumbar fascia, 4 or 5 segments up and 4 or 5 segments down, and it is also enters into the intervertebral foramen and block all these segments and stays there for a longer time. Just because it goes and blocks the somatic as well as sympathetic fibers, the visceral pain is also blocked for a longer time. These are all the dye pictures on cadaver and how much they spreads for a larger areas. Then the quadratus lumborum block, when it is given here, it is the quadratus lumborum lateral, and if it is given posteriorly, I mean behind the, in between the erector spinae and the muscle, it is called posterior, and when it is given here, it is called the anterior. Inside the muscles also we can give. And the quadratus lumborum block, as I told you, it is more wider spread, and the visceral pain is also blocked and the longer duration of action. So this is how the needle comes from the posteriorly. Here is the thick, dark quadratus lumborum muscle, and at this junction, you can deposit this muscle. This is psoas major. So here you deposit this drug and around 20 ml. That gives a very good analgesia for about 24 to 48 hours. So then the next question arises, neuraxial morphine is good or bilateral quadratus block, which is good for that? So the answer after a review meta-analysis done in 2020, they conclude quadratus lumborum block was superior analgesic effect when combined with when compared with systemic opioids. It reduces the postoperative opioid consumption when you use systemic opioids. When intrathecal morphine is instituted in a patient, it is not administered. So you need not administer bilateral block. So the conclusion is neuraxial morphine and bilateral QL block is good enough. So you need not combine both. A similar paper in 2020 in another cohort, meta-analysis, they also conclude quadratus lumborum improves the post-caesarean delivery analgesia in parturition and who has not received neuraxial morphine. Quadratus QLB block in parturition received neuraxial morphine has no significant analgesic effect. Then comparing this there is insufficient data to draw a conclusion whether neuraxial, when we give neuraxial block, the TAP block or QL block, which is the best if you don't give the neuraxial block. There is a insufficient data to conclude which could be the best. In my personal experience, QLB block is better than the TAP block for a duration of action. So what are all the indications for this muscle plane block will be to conclude caesarean section done under GA. In caesarean, when intrathecal opioids are not used, and sometimes some patients will request for additional anesthesia in the first or second postoperative day. In those cases, we can use this blocks. Then coming to the complications. Of course, every procedure has got its own complications. So the complication here will be a toxicity of the drugs. So excess toxicity of the drugs, because when we use a larger dose without calculating the dose, we give the drug toxicity will be increases and the incidence will increase. Moreover, this pregnant patient may be susceptible for toxicity. So we have to be very careful. As I told you, guaranteed sterility should be there in all our procedure. Very rarely in quadratus lumborum block, vascular injury can occur. Vascular injury, the lumbar arteries are there sometimes in the junction of the two muscles, and it should not be injured. And sometimes if you go deep, it may enter into this next muscle plane and produces the lumbar plexus block. So the patient may not be able to move the limb for a couple of hours more. So that is, and the patient may not like it. Another difficulties we face with quadratus lumborum block will be, we will be putting the patient in the lateral position. So imagine a patient during pregnancy or even after delivery, putting on a lateral position on either side, you require a large manpower to help yourself to do this procedure. Next group of drugs will be our non-steroidal anti-inflammatory drugs. So it is have been in the market in the use for the past 20-25 years. We all know the NSAIDs are anti-inflammatory, inhibit the cyclooxygenase enzyme system, therefore decreases the prostaglandin production. So NSAID reduces the postoperative morphine consumption by 30 to 50%, and the very small amount is transferred in the breast milk. And during the process of enhanced recovery, all these societies like the Society of Obstetric Anesthesia and Perinatology, American College of Gynecology, ACOG, all the societies approve NSAID use as a part of multimodal anesthesia system. So it is established that ketalog 30 milligram via intravenous or intramuscular dose is always useful and it can be followed. And of course, we have to choose the patient. The patient, very rarely the patient with renal compromise, we should not use. And even in patients with pre-eclampsia, hypertension, eclampsia patient also, recently it has been used without any side effects. Next group of drug we always use now is acetaminophen, that is the paracetamol. Paracetamol supposed to inhibit the peroxidase, leading to reduction in prostaglandin formation. And it also supposed to interfere with the descending serotonin pathway of pain. And it reduces the 24 hours morphine consumption very much, up to 20% it reduces. Of course, we have to repeat the dose once in 8 hours or 6 hours, depending on the patient condition. And nowadays, this recently published development of evaluation of the obstetric quality recovery score after elective cesarean delivery. So how to validate our procedure, how to know how much we have satisfied the patient. Some way of scoring should be there. This has been evolved. This is by 4 criteria are taken like this. Physical comfort. In this subclass, nausea, vomiting, shivering, and whether she has got any dizziness. The emotional state of the patient is also taken into for scoring, whether it is in control or comfortable. And the physical independence, so that she can mobilize independently, take care of this child. And the psychological support, whether she is able to communicate with the staff and family, like this. 11 points are taken into consideration. And so we know our procedure is really doing good for the patient by this scoring system. Recently, the prospect guidelines for elective cesarean section has been published, and they have got a few recommendations. I have summarized these recommendations. So first thing, we have to identify this patient by taking history, and preoperative anxiety has to be checked in, preoperative pain, all these things has to be evaluated from the patient. And then you have to plan the intraoperative procedures. For instance, very anxious patient, not cooperating those patients, when you give spinal anesthesia, they will be very much dissatisfied. So we have to sometimes resort for general anesthesia. And these type of patient, we have to go for an aggressive postoperative anesthesia, preferably a catheter technique, epidural catheter if necessary, sometimes multimodal anesthesia, that is always we practice. And all these things, aggressive anesthesia should be planned in the preoperative itself. Then we plan for NEURAXIAL anesthesia. Then we have to go the standard care, that is, if possible, in all the cases, we can use morphine, 50 to 100 mg. And suppose if you use go for epidural, then as I told you, 1.5 to 3 milligram. A scheduled NSAID has to be given. That is either ketorolac or diclofenac, and it has to be later converted into oral therapy. And of course, paracetamol can be given 8 hourly 1 gram for the first postoperative day, and it can be tapered. Some people prefer to use dexamethasone, additional support. Suppose if we go for general anesthesia, definitely we have to consider regional anesthesia for continuous infiltration, either tap block or QL block or continuous infiltration. And of course, NSAID and paracetamol in the manner we have described. So if there is adequate analgesia, well and good. If there is no adequate analgesia, then there is an ongoing severe pain. Then you have to repeat and consider about other regional anesthesia technique, continuous infiltration like this, and then IV oral opioids, and sometimes gabapentin or even ketamine has to be used in extensive when the patient demand is too much. There is a very rare instance only. So anyhow, the key of success in all these things will be monitoring the patient the postoperatively. Whatever analgesia we give, we have to monitor the patients carefully, and also a considerate nursing is very essential to comfort the patient at distress. Thank you, sir. Thank you.
Rajesh, sir.
Thank you, sir. Thank you, Kannan sir, for your nice lecture. And you explained all the basic things. And we have some questions in the chat box, sir.
Sure.
Sir, NEURAXIAL fentanyl, is it the duration or quality of the analgesia is improved with that NEURAXIAL fentanyl? Just the duration or the quality of analgesia per se?
Yes. The duration, the three things are improved when you give fentanyl. The onset time is also to some extent reduced when you use fentanyl. One. Second thing, the duration is also improved, and the quality of analgesia is also improved. Suppose if you have to give, you can reduce the actually bupivacaine dose when you use about 25 to 30 micrograms of fentanyl. So all the three will be improved by using fentanyl. But only thing, the longer duration, it may not be work out very well.
Which steroids you use in NEURAXIAL or intrathecally, sir? And they want some dose also for that steroid.
Steroid always the easily available steroid dexamethasone, and I have not used this intrathecally. I use only in this regional anesthesia technique. Even epidural I have not used, but it is believed if you use even if you use intramuscularly in somewhere else, this does not require at the site of analgesia. The general dose of the steroid itself is supposed to reduce the prostaglandin production itself.
Sir, ideal time to perform the tab block, whether it is a preoperative or postoperative.
So for all other surgeries, we can say it's preoperative. But cesarean, it is difficult. You have to do it postoperatively at the end of surgery only, for the obvious reason. Right.
Yes. So the quadratus lumborum block, we have. Hello, Shiva?
Yes, I can hear you.
Oh, so actually, I had asked because recently, when performing some tab block in the post-cesarean period, it was difficult to identify the muscular planes.
Yes, sir.
Needle and the
yes,
was the difficult. That is why I had asked,
sir. You are exactly right. So it is very, very difficult. Sometimes it is impossible to identify the plane, especially in the tab block, because the muscle is edematous and the fat is edematous, and after the surgery, the tab block is very difficult unless you have an experience in doing that.
Very difficult.
But QLB block is better. It is easier. And only thing, the difficulty is positioning the patient after the end of surgery. You require at least 2 or 3 persons to help, and that is a difficulty.
Thank you, sir.
Sir, in that QL, in the
Rajesh.
QL block. Yes, sir.
Rajesh, one sec. This is in relation to a prior question where you asked about steroids, intrathecal steroids. Intrathecal steroids for analgesia, they meant.
Yes, sir. That's what the question has been asked by Dr. Prema about.
I always thought intrathecal steroids are used only for radiculopathies. That too, very rarely it is indicated. When you have transforaminal epidural steroid injections, even intrathecal, we don't use it. But generally, I think intrathecal steroids are not additives for post-op analgesia. I don't think we should be using it.
Yes, sir. Yes, sir. What you mentioned is absolutely right. I have not used anything. Even pain practitioner, we use epidural steroids and
exactly. No, there are historical references of intrathecal steroids, but I think let it stay there.
Intrathecal steroids as such for post-operative pain relief for cesarean is not indicated. Because
no
added
sir.
this point.
It's not indicated anyway.
Yes, not at all. It is also dangerous sometimes.
Yeah.
When we add for these regional blocks, we can add.
That is obviously yes. Yep.
It is meant for chronic pain, chronic regional pain.
Yes.
Sir, regarding that quadratus lumborum block, we have 3 approaches, sir. Which one will be ideal for cesarean section? Whether it's a posterior or lateral or anterior?
So by practice, because I do practice this for almost all the laparoscopy cases I do. So I find this intramuscular plane, that is anterior, is easier and more comfortable than the posterior one, because I don't know whether I am comfortable or I have not analyzed it. But of course, the lateral will cover less only. Only this posterior and the intramuscular anterior will extend into the vertebral foramen, and as much people claim it goes up to the epidural space. Lateral will not have that much of spread, it is believed.
Sir, QL versus tab block. Which one will be you quadratus lumborum versus tab
yes,
block?
Because yes, I prefer QL block because the visceral pain is also blocked very well, and it stays for a longer period because it goes into the vertebral canal and things like that. So probably the absorption is very much delayed. Whereas in tab block, the absorption of the drugs from the site is very fast. It acts only for 8 to 12 hours at the maximum. But QL block goes for up to 24 hours, especially when you use, suppose if you use ropivacaine instead of bupivacaine, it acts for a longer time.
Sir, when we select a regimen of opioid-free analgesia, so where we cannot use the intrathecal morphine, so what type of anesthesia or analgesia you will prefer?
I prefer QL block.
Okay, sir. Will there be any difference in the postoperative pain relief or side effect profile when we use long-acting lipophilic opioids versus hydrophilic opioids in the cesarean?
I have no idea about that. I have no idea.
Okay, sir. And, sir, regarding the fentanyl or buprenorphine patches of cesarean section.
So that I always discourage, because discourage it, because it takes up action for 3 to 4 hours, and if you don't want, if you remove the patch also, it acts for 3 to 4 hours. It is very difficult to reverse those things. So fentanyl patch and all these patches are meant for chronic pain of some palliative treatment or some, not for cesarean, not for cesarean.
Sir, intrathecal buprenorphine in pregnant patient, is it okay to use it? Intrathecal buprenorphine.
Yes. Intrathecal buprenorphine has been used all over India by all anesthesiologists. But only thing, meta-analytic studies has not published properly. Okay. So that is a problem.
So will that be superior to intrathecal morphine?
So anybody who publish, we welcome it, because I also use buprenorphine, but I have yet to compare with in a systematic way. So that is the thing that is lacking. So you youngsters can do that.
Magnesium sulfate. Role of magnesium sulfate in post-op pain relief for cesarean.
Yes. So it is believed sometimes some neurological problem occurs in when you use magnesium intrathecally. Some people believe this, and those people who discourage them using intrathecally, but they say you can use it epidural. So whenever somebody says is intrathecally, it may produce some degeneration. We are all little bit scared to use this drug.
So
IV
which one
also
is
they
it?
can use. Magnesium sulfate, I can use in IV also, sir. Intravenous only.
Yes, sir.
Intravenously, you use it to reduce the, improve the analgesia.
The multinodal analgesia.
Yes. Okay.
Sir, FDA approved drug for intrathecal adjuvant in pregnancy.
This is FDA approved is only three, to my knowledge, three drugs: morphine, fentanyl, and sulfentanyl.
Okay.
I do not
the
know
Western.
whether. Pardon?
No, next question. Okay, sir. Okay. The next one is like the Western recommendation regarding the Western recommendation of intrathecal morphine. The dose which they recommend is 50 to 150 nights. So is that justified to use the same thing in Indian population?
Yes, they can use, because why do you say Indian population by weight? They are also almost 90% height and weight. And I do not know whether Indian population requires less drug.
Okay, sir. So is there any contraindication for the use of NSAIDs in pregnancy in view of the thrombotic?
Yes. Whenever the thrombotic problem is there, some patient may have renal function test is deranged, and established cardiac patients. We can prevent. We need not use those drugs in that. But in preeclampsia, I searched the journals and other things regarding this preeclampsia using NSAID, and it has been a few papers they are published that there is no side effect of using NSAID in preeclampsia patients.
Okay, sir. Thank you, sir. Thank you. You have almost answered all the questions from the chat box, I think, sir. Edward, sir, no more questions, no, sir?
No more questions.
Shall we conclude? Okay, sir. I will
Thank you very much.
Thank you, sir.
Thank you,
Kannan, sir.
Thank you, sir, for giving me an opportunity. Thank you. Meet you all. Thank you.
So we will move ahead with the second topic for today. That is guidelines for neuraxial anesthesia following anticoagulant and the antithrombotic drugs. And we have another stalwart in obstetric anesthesia here to deliver the lecture. And real proud moment of my life to introduce my favorite teacher in anesthesia to this forum, Dr. MADHUSUDAN UPADYA, alias Madhu sir, our favorite Madhu sir, is a professor from KMC Mangalore, and a very eminent teacher in motivating and inspiring the postgraduates, creating many stalwarts in the field of not only in anesthesia, in pain medicine, critical care medicine, and emergency medicine. And if you allow me, I'll be talking to the whole day about him. He had given so many lectures in international forums and national level forums, more than nearly 200 lectures and more than 50 publications. And he is an editorial board member of Indian Journal of Anesthesia. So much passionate towards obstetric anesthesia, and also so much passionate towards teaching the postgraduates the same. And he is a member of Obstetric Committee, WSA, World Federation Society of Anesthesia from 2016 to 2020, held various posts in KMC Mangalore as head of the department, medical superintendent, and organized many conferences, including that one sir has mentioned, there was the South Zone Conference, is a conference, a very successful event, and the last alumni meet which we had in 2016 MAT. Over to you, Madhu sir, for the topic.
Thank you so much, Rajesh. I think that was one of the most wonderful introductions I have ever heard about me. But I don't think I deserve all this. I have been a teacher. I have been trying to be a mentor. And I think all of us, we should be basically at a certain stage of our life, we should try to be mentoring rather than just teaching. And it's actually a proud moment that the alumni are doing very well, because ultimately we make the alumni, but then alumni make the institute. That is what is said. Therefore, I am proud that you people have reached places. That's enough about ourselves. Thanks very much, Edward and Rajesh, for having invited me to talk on this very important topic. But let me apologize in the beginning that I'm not focusing only on obstetrics. I'm only talking about the ASRA guidelines in general, and I will speak about obstetrics as and when is required, and then finally I will take questions as usual. Because if I speak about anticoagulants and regional anesthesia and obstetrics, the talk would be over in 10 minutes, 15 minutes. Yeah, therefore I thought I would make it a little more exhaustive. Over the next 45 minutes, I will talk to you guys about how to avoid the hematoma in the spinal canal. Basically, the spinal canal hematomas, whether it is epidural or intrathecal, they have disastrous consequences. Basically, because when you fail to detect the hematomas or the features following the compression of the spinal cord or the nerves, the consequences of paraplegia can be disastrous for the patient and then for you professionally, because it's very difficult to answer the legalities, legal experts when it comes to the criminal court or the consumer court. You hardly have time, because usually what happens is when the patient complains of increasing depth of sensory blockade or increasing depth of motor blockade, you tend to shy it away, wash it off, saying that it might be because of the local anesthetic, and you start blaming the local anesthetic drug which has gone into the subarachnoid space or into the epidural space. But when you realize that it is neither because of the local anesthetic or whatever, then the time is too little at our disposal. Unless you detect the hematoma within the first 8 hours of hematoma starting developing, the patient will survive with the after effects. The patient will have forever, will be cursing you for the paraplegia or paraparesis which you give the patient. Even if the laminectomy and evacuation is done after 8 to 24 hours, the results may not be that good. You have to detect and treat within the first 8 to 24 hours, then only the patient will have better outcomes. Therefore, I will focus on avoiding the hematoma, whether it is obstetric practice or otherwise. And unfortunately, when we grew up, we didn't even have clopidogrel in the market. Therefore, now not only the clopidogrel, we have a host of anticoagulants and fibrinolytics in the market. Therefore, every practicing anesthesiologist should be aware of the effects and the half-life, and finally, how to reverse any of these drugs' effects. Everybody should be aware and should be practicing the right things. There's no place of complacency in treating the patient or anesthetizing the patient when the patient is on an anticoagulant. If you don't know the half-life, if you don't know what the anticoagulant does, which brand, which generic drug it is, you should take time off and learn about the drug and then go back and anesthetize. Never hurry the things up. Okay. The incidence of spinal hematomas are actually, it is quite rare. It doesn't happen quite often. The incidence of epidural hematomas is as low as 1 in 220,000. And when you talk about spinal hematomas, it is 1 in maybe 150,000, 1 in 1.5 lakhs. The incidence is quite less, but still the problem is when it happens to the individual, you cannot escape the liabilities which come with that. And it's an era of consumerism, therefore we have to be extremely careful. There haven't been many studies. Basically, you can't do an RCT, you cannot do an observational study on this kind of numbers, because over a period of time, if you see in your lifetime, you may not see any spinal hematomas. Therefore, it's very difficult even when you go retrospective and try to find the number of hematomas, which is iatrogenic. It's very difficult to have an RCT. It is very difficult to have. Even an observational study. That is why even the ASRA or American Society of Regional Anesthesia and Pain Medicine, or its equivalent on the European side, ESRA, they have come up with the guidelines, but most of the recommendations on the guidelines, they are not based on RCTs or systematic reviews or meta-analysis. As I said, it is not possible to have them. Therefore, the level A evidences are lacking, even when you talk about the ASRA guidelines. But be assured that in the court of law, you can always quote the guidelines. The guidelines are there basically. There are a lot of instances where the judges or the lawyers ask you about the guidelines. Do you have recommendations, guidelines regarding this particular issue in our country? That's why, though Indian Society of Anesthesia has been looking at developing guidelines for various aspects of anesthetic, we have already published a few, including the fasting guidelines. But unfortunately, the regional anesthesia and anticoagulation hasn't been prepared yet. Unfortunately, I'm also a party to that. We have been a little slow on developing the guidelines. Hopefully, in another 2 to 3 months, we will come up with the guidelines and then publish them in the Indian Journal of Anesthesia. And then maybe practicing anesthesiologists can quote them when it comes to that. Therefore, right now, we'll focus on the ASRA guidelines, and people can also refer to the ESRA guidelines, European Society guidelines. And there is not much of a difference, maybe some subtle changes from the ASRA guidelines. But I think the periodic changes in the ASRA guidelines, I think we have been following them. It's green all times, therefore you can still use them and quote them. But be familiar with the ASRA guidelines to all the postgraduates and the practicing anesthesiologists, because that is the basis on which we practice our anesthetics, especially when it comes to regional anesthesia and pain medicine. And earlier, the regional anesthesia, we were only worried about the anticoagulation and regional anesthetics, but now the pain medicine is also included, because I will come to that a little later. Unfortunately, as I said, there have been a lot of anticoagulants and fibrinolytics in the market, and it's actually has caught up the fancy of most of the cardiologists to start the patient on the newer agents. I really don't know the rationale why they choose a particular drug over another one. But then you also have a bunch of general practitioners, general physicians, and cardiologists who put the patients on prophylactic clopidogrel and aspirin. That is where you actually get killed. you may miss because when you ask about the comorbidities with the patient will say, I don't have any comorbidities. And then when he takes out from the pocket, the drug list, it has clopidogrel. Why was it started? He said, you are 65, it is better to have. That is what will land us in trouble when we anesthetize. But anyways, that's part of the game, and we have to move on with the fancies of the other physicians. Obviously, when the patients come with anticoagulants, patients are managed with anticoagulants, there's an increased risk of hemorrhagic complications. I've been talking about that only till now. And there's a chance that the patient develops vertebral canal hematoma. And as I said, the permanent neurological complication is possible if it is not rapidly recognized and treated. Please remember the postgraduates, there are two deadly events which can trouble you. One is epidural abscesses, when you are not sterile enough, when you invade into the epidural space or the subarachnoid space. And then the vertebral canal hematoma. Both the situations where I said you are left with very short time interval to diagnose and manage. That's why whenever you put up a chart of postoperative analgesia, you train your nurses in the PACU or beyond in the ward to make sure that they assess the patient's motor blockade and sensory blockade every second hour. It's mandatory. Then you will not miss if the patient has a developing hematoma or an abscess. Okay, abscess takes time. Even if it is hematoma developing into an abscess or per se the infection introduced, that's a little difficult to diagnose because it's gradual over a period of time, and by the time the patient becomes bad, you will not have time. Let's not focus on that. We will only focus on the hematoma or the hemorrhagic complications. Okay, but as I said, stick to the guidelines and you will not repent. As I said, the ASRA and pain medicine comes up with guidelines very frequently, and 2018 was the full guidelines, and 21 there have been some addendums added to it, and I will go by those guidelines. And then we'll also talk about the conventional anticoagulants and how it is related to central or neuraxial blocks. Then there are quite a few novel oral anticoagulants again, which have caught up the fancies of the cardiologists and others. Therefore, we should know about them also. And then finally, a couple of slides on the CHADS2 scoring system. I'm sure you people know what is CHADS2 scoring, but I will just talk about that. There are a lot of pain physicians who said, I am not very invasive. I'm only doing an epidural steroid, transforaminal epidural steroid injection. Do I still bother about the anticoagulants the patient is on? The answer is yes, because you can still have hematomas in wherever you have gone into. For example, when you look at the history, epidural steroid injections, transforaminal, which was done by the pain physicians, maybe under the CIAM guidance, they still have had hematomas forming. There have been at least a couple of case series where about 9 cases have been reported. I think it's worth treating, even the pain physicians treating the patients as though we are going into the epidural space or intrathecal space, or giving a block just like a generalist does in anesthesia. Okay, we have to stop the anticoagulants. Rajesh. Available guidelines recommend time intervals. The couple of questions which are asked always are, after stopping the treatment, at which time interval performing regional anesthesia technique may be safer? Obviously, that is what you have to ask yourself, and then seek answers whenever your patient is on anticoagulants or fibrinolytics. And at which time treatment with anticoagulants and or antiplatelet drugs can be restarted after the procedure or removal of an epidural catheter? Or still worse, can the anticoagulants be restarted when the epidural catheter is still in situ? We will seek answers as we go by. over the next maybe 40 minutes. All right. The questions asked are when is it safer to perform the regional anesthesia technique or whatever with invasive procedures after stopping the treatment with anticoagulants. The other one is when can you restart the anticoagulants after the surgery, or can you continue with the epidural catheter in situ when the patient is on, and or can you restart the anticoagulants? What are the factors that increase the patient's risk of bleeding? Female gender is very common. When you look at the series of case series retrospectively, where they have searched from 1906 to maybe 2020, about 65% or 70% of the patients have been females who have had the spinal canal hematomas. Age more than 65 years, obviously. History of early bruising and excessive surgical bleeding, that should provide a pointer towards why your patient is bruising, and the patient might have a spinal canal hematoma. When the spinal column abnormalities, the patient presents with spinal column abnormalities, they're basically because it's you need multiple attempts, and they can be traumatic. That's why if you puncture a vessel here and there, when you keep on trying for your spinals or epidurals, obviously the patient can end up with a spinal canal hematoma and renal insufficiency, because all these anticoagulants which are used, obviously the patient's the action of the drug will be prolonged, and when you believe that the clopidogrel can be stopped for 5 to 7 days, and then if the clopidogrel still stays in the body and you try the invasive technique, patient might have a bleeding or risk of hematoma is higher. When you talk about the risk associated with the anticoagulants, the guidelines are stratified for low, moderate, and high risk procedures. What are the low risk procedures? Usually the peripheral nerve blocks, especially under vision, when you use an ultrasound, or when you get into a joint to inject drugs. Moderate and high risk procedures include deep plexus blocks like lumbar plexus blocks, or you are trying a deep sciatic block. Epidurals and central neuraxial blocks, and then invasive catheters, wherever you want to place them, they come under the moderate to high risk procedures. At all times, it's worth remembering Greenblatt's elimination half-life of drugs. Basically, we all believe that if we wait for 2 half-lives of an agent is sufficient. And Greenblatt clearly in the graph plotted on the right side has clearly plotted it, charted it out, saying that after 2 half-lives, 25% of a drug is still remaining in the plasma. And after about 5 half-lives, only 3% of the drug remains. That is basically an adequate reversal. Therefore, you have to wait for 5 half-lives of any anticoagulant before you decide to invade into the for the central neuraxial blockade. All right. After 2 half-lives, there is 25% of the drug remaining in the plasma. But after 5 half-lives, it's only 3 drugs, which may not be giving you clinically important action of the drug. Therefore, you can safely use any of your techniques after 5 half-lives. Okay. With that introduction, we'll talk about a few of the anticoagulants and how they are related to central neuraxial blockades or procedures. Okay. We'll start with the most basic drug, which almost 50% of the population would be on, aspirin. And when I say aspirin, we are talking about the high dose aspirin. It's classically said that up to 150 milligrams is called a small dose aspirin, and 151 milligrams onwards per day is supposed to be a high dose aspirin. Therefore, we are looking at the high dose aspirin, which is more than 50 milligrams, 151 milligrams per day. Okay. On any given, at any given time, 10 to 15% of the circulating platelets are normalized each day after the discontinuation of the aspirin therapy. 10 to 15% of the circulating platelets become normal because that much is secreted every day, produced every day. And 4 to 5 days after the discontinuation, you should have about 50 to 60% of the circulating platelets, which are unaffected by the aspirin. Because basically because aspirin and NSAIDs inhibit COX, cyclooxygenation, cyclooxygenase enzyme, which prevents the formation of the potent platelet aggregation of thromboxane A2. They are indicated at low doses for primary and secondary prevention of stroke and myocardial infarction. Therefore, generally what you use, the aspirin or even the NSAIDs, small dose is for prevention of stroke and myocardial infarction. That is why, as I said, most of the people come with the aspirin nowadays. Aspirin affects the platelet function for the duration of the platelet life, but NSAIDs affect the function only temporarily. For the ASRA guidelines recommend no additional precautions in patients treated with these medications before the central neuraxial blockade performance. And we, the anesthetists who perform regional anesthesia, the guidelines are to continue the therapy, but the pain guidelines are the same for low risk procedures. But if it is too invasive for the pain procedures too, you are supposed to stop the aspirin and then you can perform the procedures. But moderate to high risk procedures are more problematic. ASRA recommends that you discontinue aspirin for 6 days in primary prophylaxis and 4 days for secondary prophylaxis. Depends again on the dosing, and if the dose is small, you can you still stop for a moderate or high risk procedure for 6 days. Platelet glycoprotein 2B and 3A receptor antagonists, tirofibam, abciximab, eptifibatide are the examples. They are the platelet glycoprotein 2B and 3A receptor antagonists. They inhibit the platelet aggregation via interference with platelet, fibrinogen, and platelet von Willebrand factor binding. The time intervals are based on the time to return to normal platelet aggregation. The intervals basically are longer for abciximab, 24 to 48 hours, than for eptifibatide and tirofibam. That's about 4 to 8 hours. Therefore, if your patient is on abciximab, you have to stop for more than 48 hours before the patient is ready for your regional anesthesia. All right. The most commonly used drug is P2Y2 inhibitors, and the examples are clopidogrel, prasugrel, and ticagrelor. They inhibit the platelet aggregation, and regional and pain guidelines are the same for discontinuation of these drugs. However, each drug differs slightly. They're safe to resume in 12 to 24 hours post-surgery, but it takes several days for P2Y2 inhibitors to reach the peak effect. But still, do not resume a loading dose or peak effect will occur too quickly. And if the spinal anesthetic has been given or epidural has been put in, the patient can start bleeding if you give a loading dose. If you start the regular oral dose after 12 to 24 hours, the chances that the surgical site bleeding or bleeding into the subarachnoid space or epidural space is not that significant. Okay. Basically, the P2Y2 receptor antagonists include the thienopyridines like clopidogrel, prasugrel, ticlopidine, and then there are non-thienopyridines like ticagrelor and cangrelor. The ASRA guidelines recommend discontinuing all these drugs, excluding the cangrelor for 5 to 7 days before receiving a central neuraxial blockade, 10 days for ticlopidine. When the patient is on ticlopidine, make sure that the patient is off for 10 days. The new trend, what I'm sure everybody would have been going through this, even the cardiologist who is treating the patient would say 3 days if he is off clopidogrel, that's enough. I don't know where this 3 days have come in the guidelines, which are non-existent. Therefore, don't fall for it, even if the 3 days stoppage has, if you believe, has legal implications. It's not, because the evidence says that it is 5 to 7 days. All right. Therefore, minimum of 5 days and better is 7 days. Bridging therapy is a completely different ball game. It depends on what the patient, why the patient is receiving the clopidogrel. If the patient is on clopidogrel or any thienopyridines, if it is for the stent in situ, obviously, depending on the stent, you have to look at the bridging therapy. If the adequate time has lapsed after the stents have been placed, like drug-eluting stent, you wait for 6 months for the elective surgeries, and the bare metal much lesser. But still, after the 6 months have elapsed after the drug-eluting stent, you still have to stop the clopidogrel for 5 to 7 days, but you may not look at the bridging therapy, which may not be needed. If it is within the first 6 months, depending on the seriousness of the condition, whether the surgery is badly needed, then you can look at the bridging therapy, right? Cangrelor should be stopped 3 hours prior to the administration of a neuraxial block. And as I said, non-loading dose of clopidogrel, prasugrel, ticlopidine, or whatever can be given immediately after the catheter removal or block performance. Okay, we'll talk about the epidural catheter in situ and a little later with all the drugs. When clopidogrel is stopped for only 5 days, the platelet function testing is indicated. You have to look at the qualitative functioning of the platelet. Don't just look at the numbers, because numbers may not change if it is only used for, stopped for only 5 days. Otherwise, you hold it for 7 days. And the P2Y12 assay reflects similar results when clopidogrel is stopped for 5 days versus 7 days. It indicates less than 10% of inhibition. And then not every hospital or institution can proudly say they do P2Y2 assay. Therefore, conveniently, you can look at the platelet functions. With an indwelling neuraxial catheter, clopidogrel or ticlopidine can be given from 24 hours postoperatively. And if a loading dose is not given, the catheter should be used only for 1 to 2 days. A word of caution, there have been case reports of MI, myocardial infarction, 6 to 7 days after clopidogrel was stopped. Therefore, immediately after the post-surgery, when the risk of bleeding comes down, you should be starting the conventional dose of clopidogrel or any other P2Y12 agents. Talking about the warfarin, we all know that warfarin inhibits vitamin K-dependent clotting factors 2, 7, 9, and 10 synthesis. And ASRA guidelines recommend a normal INR, which is less than 1.1. And administration of the drug with a neuraxial catheter in place is acceptable with caution. For example, neurological observations of sensory and motor function, which has to be done very frequently. As I said, if possible, every second hour, when the INR is around 1.5 to 3. And the catheters can be removed with an INR of less than 1.5 and continued neurological observation for another 24 hours. And beyond that, there is not much of a risk that the site where the catheter has been sited bleeds. Therefore, you observe for 24 hours and then can be happy. Can warfarin be reversed? Warfarin can be reversed with vitamin K in the absence of major bleeding. Like an IV infusion of vitamin K acts within 6 to 8 hours. And you can also prophylactically, if the warfarin has been stopped for 5 days, you can, if the INR hasn't normalized, you can also look at oral vitamin K. And as far as possible for an elective surgery, don't try the shortcuts like reversal with vitamin K. And you do that even after, maybe after the INR refuses to normalize, even after 5 days of stoppage of coumadin derivative, that is warfarin. Okay. And prothrombin complex concentrates can also be used to reverse the warfarin effects. Dipyridamole is used to prevent ischemic stroke, and ASRA guidelines recommend discontinuing the extended release formulation 24 hours before the central neuraxial blockade. The agent should not be given with a neuraxial catheter in situ. Dipyridamole should never be restarted when the epidural catheter is in situ. Cilostazol it inhibits phosphodiesterase 3A and thus platelet aggregation. ASRA guidelines recommend discontinuation for 48 hours before the central neuraxial blockade performance. Dipyridamole for at least 24 hours and cilostazol for 48 hours. Now we talk a little bit about heparin, the unfractionated heparin. It binds to antithrombin, leading to the inactivation of thrombin, this factor 2A, factor 10A, and factor 9A. Intravenous heparin acts immediately, while subcutaneous heparin, which is administered at a dose of 5,000 international units, it exerts its effects only after 1 hour. And the ASRA guidelines recommended time intervals are dependent on the route of administration, basically. And for subcutaneous unfractionated heparin, dosing too. The time intervals between before the central neuraxial blockade for subcutaneous heparin can be up to 24 hours after the last dose. Though intravenously administered heparin, we take the liberty of doing the procedure in about 6 hours time, because it acts for only about 4 to 6 hours. But if it is subcutaneous, then you have to wait for 24 hours at least after the last dose. And patients receiving unfractionated heparin for longer than 4 days, it's a possibility that the patient might have heparin-induced thrombocytopenia. Therefore, you have to do a platelet count before the central neuraxial blockade or catheter removal or whatever. All right. The hit is a possibility. When receiving the IV heparin after spinal or epidural, you wait for about 1 to 2 hours, and the half-life depends on the dose. This becomes clinically relevant for high doses used in cardiac surgeries. Subcutaneous, the BD dosage of heparin subcutaneously, the regional guidelines vary based on the dose. And when it is TID, because the TID practice is relatively new, and previously regional guidelines were not to perform the procedure. However, recent studies indicate that we can safely perform spinal and epidurals in patients with TID subcutaneous heparin too. But be aware that surgeons are not likely to go back to BID dosing, as it is less effective. Therefore, if he has started with the TID dosing, he will continue with the TID dosing. And when there is a TID dosing, you have to be extremely cautious. Maybe you cannot perform the procedure when the at least 24 hours when the heparin is going. The low molecular weight heparins, they inhibit the factor 10A and are indicated for venous thromboembolism prophylaxis and treatment. And the guidelines recommend against routine testing of anti-factor 10A levels, since there's no known safe level for performing CNVs, irrespective of the anti-factor 10A levels. Therefore, You have to go by basically the timelines after the low molecular weight heparin. A 12-hour time interval should be considered after neuraxial puncture until the first prophylactic dose, and a 24-hour time interval for therapeutic low molecular weight heparin. You maintain the catheters if the patient receives a prophylactic dose daily, and the catheter should be removed 12 hours after the last daily prophylactic dose. Exercise caution when the patient is obese on higher doses, and the time of discontinuation then is absolutely dose dependent. Few of the low molecular weight heparins, fondaparinux, danaparide. Danaparide is out of the practice, therefore it is not. It's withdrawn from the market, therefore it's not covered by the ASRA guidelines. Talk about the fondaparinux, and it's a factor, obviously 10A inhibitor with a longer half-life, like about 17 to 21 hours. And for regional anesthesia, there is no recommendation, but the pain recommends discontinuation for 5 half-lives. And a central neuraxial blockade is only appropriate in the following circumstances for a patient treated with fondaparinux: single needle pass, a traumatic procedure, and no neuraxial catheter. That is what we have been taught even after the patient's clopidogrel has been withdrawn. Single needle, preferably an traumatic procedure, avoid multiple punctures, and try to use a Whitaker needle, which is supposed to be a traumatic needle, and never insert an epidural catheter. All right. Talk about direct thrombin inhibitors, argatroban and bivalirudin. Direct thrombin inhibitors, their effects are monitored via activated partial thromboplastin time, APTT, and last for about 3 hours after IV administration. And if the patient has been on the direct thrombin inhibitors, neuraxial techniques are not recommended. Thrombolytics or fibrinolytic agents. The thrombolytic agents, they interact with plasminogen to produce plasmin that lyses links between the fibrin molecules to dissolve clots. These drugs are used in acute myocardial infarction, pulmonary embolism, and cerebrovascular accidents. These drugs generally have very short half-lives, about 3 to 4 hours, but the recommendation is to discontinue for 48 hours at least. And neuraxial puncture should only be considered in patients who have clotting studies, including the fibrinogen count, as normal. In addition, the patient should be neurologically monitored every 2 hours, and ideally avoid this scenario and wait for 72 hours. Therefore, you perform the neuraxial puncture only at about 48 to 72 hours after these drugs have been administered. A few words on the novel oral anticoagulants. There are no studies on NOACs available right now, so guidelines are based purely on the pharmacokinetics of each of these agents. ASRA basically decided to use the 5 half-lives to determine when NOACs are discontinued, because only 3% of the drug will remain in the plasma at the end of 5 half-lives. It takes about 8 hours for stable clot formation. Therefore, resumption of NOACs is based on this observation. And regional recommendations are to resume after 6 hours for low-risk procedures and 24 hours for high-risk procedures. Do not restart immediately after the surgery. The factor 10A inhibitors, they are used in plenty right now for rivaroxaban and apixaban. For rivaroxaban, the time intervals depend on the dose and the patient's renal function. Rivaroxaban and apixaban have similar time intervals like rivaroxaban, that's about 72 hours. And you have to monitor with factor 10A assays. And unfortunately, most of the institutions, they don't have the factor 10A assays. Therefore, safe to wait till the drug gets metabolized and is out of the body, at least wait for at least beyond 72 hours after rivaroxaban. Dabigatran is indicated for the prevention and treatment of venous thromboembolism and to lower the risk of a stroke. The time intervals largely depend on the patient's renal function, as 80% is excreted by the kidneys. Lab monitoring is basically PTT, but the relationship is not linear. Therefore, you cannot just go by the PTT to look at the effectiveness of the dabigatran. The ASRA guidelines recommend a time interval of 5 days, that's 120 hours, after the last dose before the neuraxial puncture in the absence of renal function measurement. If your renal functions are normal, even then I think it's safer to wait for 5 days after the dabigatran. A graduated approach based on creatinine clearance should be followed if there are no additional risk factors and a renal function measurement is available. ASRA guidelines advise against administering the dabigatran when a neuraxial catheter is in situ. Moreover, the catheter should be removed 6 hours before administering the agent again, or the other way, you have to remove the catheter and then 6 hours later, dabigatran has to go into the patient. But the NOACs can be reversed, can also be reversed. And the drug is idarucizumab, is a monoclonal antibody fragment that binds to dabigatran. The effect is seen within minutes. And the other agent is adexonate alpha. It's a protein that binds to factor 10A inhibitors, rivaroxaban and apixaban. And that too, the results are seen in a while, short while. Therefore, you can reverse the patient's NOACs, and then patient might be ready for your. I will skip this. The interesting part is the patient can be on a lot of herbal medications, and they have implications on the coagulation profile of the patient too. And regional guidelines, they are to continue the herbal medications if they are really needed. But for moderate to high risk procedures, if the patient is on garlic, high dose of about 2000 milligrams a day, it has to be discontinued for 7 days. And the other agents, Dinko, biloba, check platelets, and Donquai, it potentiates warfarin. You have to measure the INR, and Danshan, again, it affects the warfarin elimination. And INR is to be checked. Therefore, a lot of herbal medications can interact with bleeding. A little on the antidepressants. Only SSRIs need consideration, as their antiplatelet effect is the same as ibuprofen. And the regional guidelines are to continue, and pain recommends discontinue for 1 to 2 weeks, except for fluoxetine. Fluoxetine has to be discontinued for much longer time, about 5 weeks, before regional technique or the pain procedure is contemplated. What are the anticoagulation guidelines for neuraxial procedures? I will just take you through a couple of slides, and it has been taken from Stanford's School of Medicine, but this is in line with the ASRA guidelines. Look at the traditional anticoagulants first. Start with warfarin. Warfarin, you cannot try regional anesthesia nor a catheter placement when the patient's INR is, sorry, you try only when the INR is less than 1.5. But patients with indwelling neuraxial catheters, it's not, it's contraindicated. And when can you inject the local anesthetic, the warfarin after the catheter is removed or the procedure? That's about 2 hours. Okay. The heparin full dose IV, when the APTT is less than 40, you check after holding for 2 hours. And the heparin mini dose, that is 5000 units subcutaneous BID, there is no contraindication. But when the patient is on TID dosing of heparin, you check the APTT, and if it is less than 40 or if it is 6 hours after the last dose, and heparin full dose, that is 5,000, one sec, just a sec. When the APTT is 40 or 6 hours after the last dose, or heparin full dose more than 5,000 units subcutaneous BD or TID, but you check the APTT and it has to be less than 40 or 6 hours after the last dose, you can safely try regional anesthesia technique or neuraxial blockade. Fondaparinux, if the patient is on less than 2.5 milligrams subcutaneous QID, which is a prophylactic dose, you have to wait for about 36 to 48 hours. And fondaparinux, sorry, before that, indwelling catheters are okay with unfractionated heparin, and the heparin can be restarted after 1 hour of the catheter removal or before or after the surgery. Coming to fondaparinux, 2.5 milligrams, if it is less than 2.5 milligrams subcutaneously 4 times a day, as in the prophylaxis, you can do neuraxial blockade in about 36 to 42 hours. And when the patient is on 5 to 10 milligrams of subcutaneous fondaparinux, which is the full dose, the regional technique is contraindicated. And enoxaparin 1 milligram per kg subcutaneous BD, you have to wait for 24 hours. And enoxaparin 40 milligram subcutaneous BD or QID, you have to wait for at least 12 hours before you attempt spinal injections or epidural. But you cannot have an indwelling epidural catheter when the patient is still on antithrombotics, or when the antithrombotics have been started. And the fondaparinux full dose or prophylaxis, you can restart after about 6 to 12 hours after the surgery or after the catheter removal. And 24 hours after enoxaparin dose, after 24 hours, you can restart after the surgery or the catheter removal. And when it is full 40 milligrams subcutaneous, you can start about 6 to 8 hours, because subcutaneous obviously will not increase the plasma levels to that much levels to cause the bleeding. We'll talk about the newer drugs, the direct thrombin inhibitors, argatroban, bivalirudin, lepirudin, unknown, or when DTISA is less than 40 or APTT is less than 40. And dabigatran, you wait for 7 days before you attempt a regional anesthesia technique. And the drug cannot be given to the patient as long as the catheter is in situ. And when do you restart? It is basically unknown. Oral antiplatelet drugs, when the patient is on aspirin or NSAIDs, you can give, there are no time restrictions. As I said, the small dose of aspirin obviously is quite safe for surgical bleeding as well as the catheters to be removed. Clopidogrel and prasugrel, you wait for 7 days and you don't restart till the catheter is in situ. But once the catheter is removed post-surgically, you can restart the clopidogrel or any of thienopyridines within the 2 hours, because as I said, a oral non-loading dose will not increase the plasma levels to that level to cause bleeding. But ticlopidine, you have to wait for 14 days before you attempt a regional anesthetic technique. Again, you should not restart when the catheter is sensitive. GP2B3A inhibitors for abciximab, you have to wait for 48 hours, and eptifibatide, you have to wait for 8 hours, and tirofiban 8 hours. It's contraindicated. You cannot start these drugs when the catheter is in situ, and you can restart this 2 hours after the catheter is removed or when the surgery gets over. Thrombolytic agents, alteplase, full dose for stroke or MI, etc. 10 days, you are not going to attempt regional anesthesia, and you will not restart it when the catheter is in situ. Another 10 days, you don't restart the drug after the surgery or catheter removed. 2 milligram dose, which is a small dose, it can be given. There is no time restrictions basically. And maximum dose is about 4 milligrams in 24 hours. It can be safely used, and you can still go ahead and do regional techniques. Apixaban, the new agents, it's unknown for the neuraxial procedures, but you hold for about 48 hours, and then you do the central neuraxial blockades or the surgery. Finally, a bit on the CHADS2 scoring. Basically, it was developed to assess the risk of developing an MI or CVA from venous thromboembolism when anticoagulants are discontinued for a procedure. CHADS2 score of 2 increases the stroke rate by a factor of 4, and CHADS2 score of 3 increases the stroke rate by a factor of 6. We talk to the patients about the risk with CHADS2 scores of 3 and consider low molecular weight heparin bridge therapy so that they are covered. What is it? C for congestive heart failure, H for hypertension, blood pressure beyond 140/90, age more than 75, and diabetes mellitus, and S2 is for prior TIA or stroke, which carries 2 points. For you have to look at the score of 2 or 3. And if it is 3, then you have to look at bridge therapy. And how do you do the bridge therapy? If the CHAD score is 0, you can look at only aspirin, 0 or 1. And beyond that, you have to look at warfarin or dabigatran as the bridge therapy too. Okay. And I think I have taken too much of your time, and I will just wind up in about 2 minutes. There is little objective. What I'm trying to talk to you about is how to use the guidelines in peripheral nerve blocks, because till now we are talking only about central neuraxial blockade. And now the peripheral nerve blocks. There is little objective information available regarding the frequency and outcome of hemorrhagic complications after peripheral nerve blocks. And if at all, and the ASRA guidelines of 21 includes a summary of 32 case reports of patients having severe hemorrhagic complications after PNBs and have observed the following trends, and it's worth knowing. Patients suffering from neurological deficits all completely recovered within the 12 months. But the 12 months would be kind of a hell for the patient as well as the anesthetist, because you will be fearing litigation at all times. Patients requiring hospitalization after developing complications had a prolonged stay, obviously. And complications in anticoagulated patients resulted more from blood loss than from neurological damage. Okay. And deep plexus like lumbar plexus block or deep peripheral blocks like sciatic nerve blocks carried a higher risk. And there was often no evidence of vessel trauma. And especially when you do these blocks under ultrasound guidance, obviously, it's very rare that you will hit a vessel and then puncture. The patient generally bleeds because the patient has been on blood thinners. Just to conclude, while these guidelines are important, individual patient and procedural factors should be considered. And the laboratory values and adherence to ASRA guidelines are not the only relevant factors to consider for preventing hematomas. Clinical discretion should be used for decision-making regarding the safety of regional anesthesia techniques. and the risks of discontinuing anticoagulation therapy in these patients should be weighed versus the benefits of neuraxial and nerve block anesthesia and analgesia. Ultimately, whatever I said in the beginning holds good even at the end. Ultimately, you have to provide safe anesthesia to the patient, and when patient is safe, you also remain safe. And how it is done is you have to follow the guidelines, you have to follow the evidence-based practices. As long as you're stuck to ASRA guidelines, I think you will be saved. Whatever you do has to have a reference in a book, and I think you will be quite safe there. All right. And yeah, there is some signal for me to end. Thank you very much for the patient hearing. And I know it has been a little too long lecture, but thank you. Thank you very much.
Thank you, sir. Thank you very much for the very nice lecture, sir. There are some questions from the chat box, sir. Sir, before moving into the questions, there is a question like how to get these guidelines. Shall I answer that, sir?
Okay, sure.
So actually, there is an app from ASRA in Google Store, Play Store. So actually, I got it some 5 or 6 years back. That time they were charging somewhere around 200 rupees. I don't know how much it is now, but that gives exclusively about all these guidelines in a simple way that we can refer from the theater itself. Like it shows for all neuraxial block, superficial peripheral nerve block, deep block,
Yes.
and for the patient who is an anticoagulant, anticoagulated parturients, and when to stop and when to restart the. It was looking very simple. So for the postgraduate, I think that will be more useful to download the app and remember all, because remembering all the numerics is a little bit difficult.
Yeah, correct.
Sir, and regarding that pain intervention, somebody has asked about the low risk and the high risk procedures. The low risk procedures in pain medicine are peripheral nerve blocks and musculoskeletal injections and trigger point injections, while all spine interventions, including your epiduroplasty or DRG, gyphoplasty, all those things come under high risk procedures. And our intermediate risk procedures includes all our sympathetic blocks. You have mentioned all those.
Yep.
Sir, when to start loading dose after a single shot spinal anesthesia? Loading dose of
yeah, obviously, I know. It all not only depends on the single shot spinal, it also depends on the surgical procedure. If the surgery, you don't expect any further bleeding, we can always restart the as I repeatedly mentioned about the clopidogrel part, where the loading dose should not be this question is on the loading doses, right?
Loading dose, sir. Loading dose.
You always wait for at least 48 hours before you give the loading dose. Otherwise, the regular dose of clopidogrel can be started immediately post-operative within the 12 to 24 hours. Otherwise, you have to wait.
Sir, will there be any change in the time interval of stopping the drug and the patient is having renal insufficiency?
Yeah, basically in renal insufficiency, most of the anticoagulants or fibrinolytics, their excretion is delayed. Therefore, if the creatinine clearance is less than 30 ml, then I think you have to delay it at least by 25 to 50% of the time. Like clopidogrel, if you stop for 5 days and then operate, there you have to wait for 7 days or beyond.
Sir, you mentioned about the platelet function testing. So how to do that platelet function testing?
The qualitative tests are done by most of the laboratories. You ask for the qualitative testing, they will give you the quality, how many percentage of platelets are functional and dysfunctional. And then you can, the surrogate testing is also about the clotting. how well and fast they clot.
Sir, regarding reversal of antiplatelet agents, particularly when the patient is posted for emergency laparotomy, dual antiplatelets, is there any way to reverse the antiplatelet effects?
No, you can. That's a little. You are taking a little bit of a risk and going in that reversal and trying some platelet infusion and FFPs. I'm not very much in favor, but you take a little bit of a risk and go in. See, for example, the NHS has changed the practice of managing the hip surgeries. When emergencies come in, basically nowadays they don't wait. The on arrival blocks, and if the patient is on a single antiplatelet, either high dose aspirin or say clopidogrel or the congeners, they look at traumatic spinals and then go in and do the surgery. It's a question of risk versus benefit. How much benefit you are going to give to the patient by doing an surgery, emergent surgery. Similarly, if the laparotomy is really emergency, you can as well go in and do the laparotomy. You don't have to worry too much about the bleeding. Then there are few people who practice this platelet transfusions and the platelet rich plasma. I don't know. That might work, but anyways, in a day, about 10 to 15% of platelets are regenerated. Therefore, maybe you can.
Sir, any role of low dose methylprednisolone in this reversing the antiplatelets?
I don't know. Edward has to tell me.
No, actually, there are some studies where they have shown that the low dose of methylprednisolone, especially in neurosurgical patients with those who are on clopidogrel, they are reversed it with low dose, 25 milligram of methylprednisolone to reverse the antiplatelet effects. And there are some
Is there any studies, sir? Low dose prednisolone reversing the.
No, I saw some case reports that very recently we discussed it. It has been done, sir. And some role is there for desmopressin also for reversing this antiplatelet effects.
Wow.
Desmopressin they routinely use.
Yeah, that is used, but
for intracranial bleeding, they use desmopressin.
No, it has some antiplatelet. It has some antiplatelet effects. It seems reversing the antiplatelet effects.
No, I'm talking about the methylprednisolone. It's interesting.
Yes, sir.
Sir, there are some centers where they routinely check coagulation profile when the patient is on dual antiplatelets. Is it mandatory?
No.
Is it a medically accepted? Because
no, it is not going to give us any value adds, right? It's not going to.
It's a postgraduate question, sir. I think so. Dual antiplatelets with this INR checking, is it mandatory?
No, it is not. Obviously, it is not. You should not. Rather, there is no point in doing it because INR is not going to be affected much there. If the patient is on warfarin, obviously I agree. But here, there is no point in doing an INR.
Sir, there are some questions to Kannan, sir. Sir, related to Kannan, sir.
Yes,
sir, intrathecal fentanyl causing itching. So, what is the line of management in that intrathecal fentanyl induced itching?
Yes, I have seen. Am I audible?
Yes, sir. Yes, sir. Yes, sir. You are audible, sir.
I have been seeing this in labor analgesia and all that. And it is only a short-lived one. It is a short-lived one. And it acts for about, this itching is there for about 20 minutes or so. And to satisfy the patient, I used to give some phenylephrine, Avil or some Decatron. And this get subsided. But if it is used morphine, then it is very difficult to reverse the effect because it acts very long.
So we can use propofol also for this NEURAXIAL.
Very small dose propofol.
10 milligram or 20 milligram.
Is it useful, Propofol?
Yes, sir. It is documented.
Yes.
Sir, what about the shivering, intrathecal opioid-induced shivering in pregnancy patients, sir? How will you?
When there is shivering, we have to only reassure the patient, and and there is no drug as such. Only placebos will help. That's all.
So, what will be your dose of intrathecal buprenorphine in pregnancy?
In pregnancy, I use that comes in 1 milligram and 0.03 milligram. That is, it comes in around 150 micrograms. Yes. And I know people who use double the dose also, but I have got no experience.
Sir, almost we are taken up all.
Sir, Kannan sir.
Yes, sir. Yes.
But buprenorphine causes a lot of vomiting, right? Intrathecal buprenorphine.
No, it is not so, sir. It is in my experience. I have not seen, sir.
Okay.
Yeah.
So literature says there is a increased nausea and vomiting in gynecological surgeries, but practically we are facing very less vomiting. Is that? Is it so?
Yes. Yes. We generally use ondansetron or some other antiemetic also that may be useful. I don't know. But as it is projected, it doesn't produce that much vomiting.
Okay.
So Rajesh sir, I want to add one more thing regarding this antiplatelet therapy in emergency laparotomy. So you need not reverse all the antiplatelet therapy treatment in case of emergency surgeries. During the intraoperative period, if the surgeon feels the bleeding is out of proportion to the normal surgery, and if the bleeding is extraordinary, then you can go for platelet transfusion. That's what the expert opinion says. Am I correct, sir?
Yeah, yeah. Right.
Sir, I have a question. Sir, I have a question. Actually, very recently, we had a case scenario, 54-year-old female patient who underwent double mitral valve replacement, and she was on warfarin. Earlier, she had proximal humerus surgery. They have done surgery under supraclavicular brachial plexus block. So it was fine. The next time she got admitted with the patella fracture, and it was done in a private hospital outside. They stopped warfarin for 5 days. They checked INR. INR was 1.2 on the day of giving spinal, but post-operatively, patient developed paraplegia. On evaluation, it was a spinal hematoma. So it was detected after 6 hours, and we couldn't. We did the surgery, but we couldn't get the results back. So how can we substantiate here? Like, will our guidelines be helpful when it goes for medico-legal aspect here? Because it was stopped, warfarin was stopped for 5 days, and INR was 1.2 on the day when they gave spinal.
Even if you look at historical or retrospective data collections, no, Rajesh, not all the patients have been on antiplatelets or anticoagulants. There were a few patients not on anticoagulants. Still, they developed spinal canal hematoma. Therefore, that is a known complication of a spinal anesthetic. You need not only focus on the anticoagulant just because she was on warfarin and which was withheld. INR would have been normal there. Therefore, it need not be just because of that. I listed out the causes, right? One of them is the difficult spinals. When the anatomy of the lumbar spinal is difficult, then multiple punctures. Obviously, somewhere you would hit a vessel, and then that is the classic teaching also, right? One of the reasons for epidural hematomas is multiple punctures. Would have hit a vessel somewhere, and it's very likely to hit the vessel. We need not only focus on the anticoagulants the patient is on. It is a known complication.
Okay, sir. Thank you. Is there any other questions, sir? Edward, sir, if the session is, there is no questions, we can
end up the session. So very good and energetic discussion today.
I'm sorry I took a little longer.
No, sir.
I thought
It's
45
an
minutes.
exam question for the postgraduate.
Okay.
So we have covered extensively. That is
No,
very
if anybody
good.
wants, I can share the PPTs.
Okay, sir.
Yeah.
People will ask for the presentation.
Yeah, I will give the PPTs. Okay.
Thank you so much, sir.
Okay, sure.
Thank you, Kannan sir. Thank you, Mansur sir. We had a wonderful session today.
Thank
The
you, sir.
elaborate discussion also, sir. So
Thank you.
with that, we come to the end of this session. I thank the Akrula, the A1 Logics, and the Anesthesia TV also. With that, we come to the end of the obstetric anesthesia series today, and we will start a pediatric anesthesia series from next week onward. Thank you, and again, and we will meet next week. Thank you.
Thank you, sir. Thank you.
Thank
Thank you.
you.
sir.
Thank
you.
you. Shall I log out, Rajesh?
Yes.
Yes, sir. Thank you, sir. Thank
Edward,
you.
bye-bye.